I'm Randy Anderson, and on behalf of our leadership group here at Science, Scripture, and Reason, welcome you to our May 2026 meeting. And we are really delighted to have Dr. Christina Cirucci with us this evening. Dr. Cirucci is a board-certified obstetrician and gynecologist and has worked for 20 years in private practice in her hometown of Pittsburgh, Pennsylvania. And she has a BS in mechanical engineering, in fact, which is pretty remarkable, from Virginia Tech, and then did her medical doctorate degree at Thomas Jefferson University in Philadelphia, and completed her OBGYN residency at the Medical College of Virginia in Richmond, Virginia. And she has also received a certificate in biblical studies from Columbia International University in Columbia, South Carolina. Dr. Cirucci is chair of the board of directors of the American Association of Pro-Life Obstetricians and Gynecologists, which is a very important voice in medicine. And so we really appreciate that effort. She's involved in research evaluating the complications of medical abortions and has published peer-reviewed articles in medical journals on this topic. She's also an associate scholar with the Charlotte Losey Institute and a fellow with Reasons to Believe. In addition to her pro-life work, she formed and led a team of scholars with Reasons to Believe to research the scientific, medical, and theological facets of transgenderism. The team has produced podcasts on gender issues as well as several white papers, and that's available on the RTB website, which was in the announcement that we sent out earlier. So, Dr. Cirucci, thank you so much for being here. We are looking forward to your presentation, and I will turn it over to you.
Well, thanks so much, and thanks for having me. It's great to be here. I appreciate everybody coming out. I am going to share my screen, so give me 1 second to do that. All right. Can somebody confirm that you're seeing my PowerPoint slide here?
Yes, yes.
All right, perfect. So anyway, again, thanks for coming out. I'm going to be speaking today on gender-affirming care, examining the evidence. So we hear a lot about gender-affirming care, and I'm going to do a little dive into the evidence behind it. And give me 1 second here. My screen is... Hold on 1 second because my PowerPoint isn't advancing. I'm going to screen share again. All right, you're seeing my slide okay?
Yes.
All right, perfect. It's working. So objectives in my talk today, I'm going to review the terminology and background about gender dysphoria. You'll find that the terminology has changed. I'm going to discuss those changes as well as the changes in epidemiology, which is like who makes up this population, and the changes in the standard of care. I'm going to go over the 4 steps of gender transition. And then what I'm going to do is look at the scientific evidence for or against gender-affirming care. Randy mentioned that I led this team with Reasons to Believe, and that was really what we were tasked to do is, well, hey, we're Reasons to Believe. We care about the science. What does the science say? Is this beneficial or not? And then I'm going to talk about the mental health aspect and then briefly touch on just the ethics of gender-affirming care. Randy mentioned these white papers. Just if you want to find these, they're free. If you go to, I don't really have the specific link, but if you go to reasons.org, Reasons to Believe website, if you search for gender, these will come up and you can get them for free. There's this one that I was involved in. There's the biblical evaluation, and then there's one on the intersex issue. So if you're older than 25 or 30, probably about 5 years ago, you thought, like I did, what happened? So I'm going to talk about that a little bit. Always want to start out, especially these days, with terminology, because People use different definitions. So this book here on the right is the DSM, the Diagnostic and Statistical Manual of Mental Disorders. This is the psychiatric Bible. So if someone has a psychiatric disorder, you go to this Bible, it will tell you exactly the criteria to diagnose that. And so the issue of gender dysphoria was first put in we call it the DSM in 1980, and the terminology was transsexualism. In 94, they changed it to gender identity disorder. And now the term is gender dysphoria. Now, if you look at gender identity disorder to gender dysphoria, what's missing? Well, disorder. They wanted to take the disorder out because they wanted to normalize it. However, it's still in a book of mental disorders because then you can get insurance treatment. And then in the revised version, they added gender dysphoria in children, and they changed some terminology. So instead of, and these are important, instead of desired gender, they changed it to experienced gender. Instead of cross-sex treatment, they called it gender-affirming treatment. And most bothersome to me, they changed natal male or female to assigned male or female at birth. Now, I'm an obstetrician. I've delivered thousands of babies. I have never assigned the sex at birth. I announce the birth, announce the sex, identify the sex. I don't assign it. But that's the terminology now. A couple busy slides. I just want to go over these very briefly. So what does the DSM say are the criteria for gender dysphoria in children? Well, they must have a marked incongruence between their experienced gender and what they call their assigned gender of at least 6 months, and at least 6 of the following: strong desire to be the other gender, preference for wearing clothes of the other gender, cross-gender roles in make-believe play, preference for toys of the other gender, playmates of the other gender, toys and activities of the other gender, etc. And then must be associated with significant distress. So I don't know. I kind of wonder if many of us would have been tagged as transgender just because we like to play with certain things. But these are the criteria for children. Adults and adolescents are a little bit different. So it's this marked incongruence and at least 2 of the following, and also associated with distress. And, 2 of the following, like wanting to rid yourself of your primary or secondary sex characteristics, desire to be the other gender, etc. Okay, so terminology has changed, but epidemiology has changed. So what that means is who carries this diagnosis? Well, historically, gender dysphoria was extremely, extremely rare, less than 5 per 100,000. And it really occurred in 2 very, very distinct populations, both males. The first population was what we call early onset gender dysphoria. So this is very young boys, 3 or 4-year-old boys who, since early childhood, had gender atypical behavior, all those things, wanted to play with girls' toys, wanted to, whatever. And interestingly, these boys, most of them, if not intervened with, what would, after they went through puberty, become comfortable being a male. So the first population, this is historically, is these young boys. And the other population is what we call late onset gender dysphoria, and also men. These are adult men who, after living years of married, homosexual, often with children, decide to transition. So think of Bruce Jenner, Rachel Levine. This is the late onset gender dysphoria. So historically, gender dysphoria, very rare, and in these 2 distinct populations. Well, what do we see now? Now we see it in adolescents. 3.3% of adolescents identify as transgender. This is over 700 times the historical incidence. And another 2% question whether they may be. Well, what happened? Here is a graph from, this is from the Tavistock Clinic, which is now closed. This is from the UK. These are the graph of their referrals to the clinic, and the orange is females. You can see how it skyrocketed this is from 2009 to 2016. But what we see now with gender dysphoria is it's not rare, it's common. It's not young boys or older men, it's adolescents and mostly female. So that all has changed. So I want to talk a little bit about the term rapid onset gender dysphoria because that's what we're seeing today. Lisa Littman was a researcher who coined this term and published a study in 2018. She did a survey of parents who experienced their child who would come home and, just out of the blue, I'm transgender, or a girl coming home, I'm a boy, with no, history or inkling of any issues in the past, just out of the blue. So she did this survey and she found that almost all of them, 83%, were female. Almost all of them had no, 4 out of 5 had no history of gender dysphoria issues. Almost 2/3 had a prior mental health issue or autism or a neurologic disability. Half of them had a prior traumatic event. 2/3 an increase in social media use. More than 2/3 with a peer group with another transgender person. And parents believe that these kids used not their own language, but language they found online. So she turned the coin, rapid onset gender dysphoria, and that's a lot of what we're seeing today. Well, people who are for gender affirming care do not like this term. I'll just say that. So this term is controversial. And then Abigail Schreier wrote this book, which if you're interested in this, I highly recommend. Irreversible Damage, The Transgender Craze Seducing Our Daughters. Very readable book. And talked about what's happening to especially our girls. And a lot of it is social media related, exposure there. And so if you are dealing with someone or have someone in your life struggling with this, highly recommend this book. Sorry, my cats are walking through. So the other thing that has changed, in addition to our terminology, is the standard of medical care. So historically, like think about these young boys, these 3-4-year-old boys, historically, what was done is what we call watchful waiting. They were just given time. They had a thorough psychiatric evaluation, but they were given time, watchful waiting, not pushed into intervention. But now what we see is what's called gender affirming care. And what gender affirming care is the person is affirmed in their desired gender with minimal evaluation. The thought is that patients know what they need. So if a girl comes in and wants to be a boy, then she can be a boy. So the diagnosis here is made by the patient, often a minor, not the healthcare provider. If you go to your doctor with abdominal pain and say, doctor, I'm worried I have appendicitis. The doctor doesn't say, well, you think you have appendicitis? Okay, you have appendicitis. No, your doctor evaluates you, runs tests, does an exam, maybe orders some blood work, and evaluates what you have going on. So, but not with gender affirming care, because if the patient says this is what I am or feel I am, then they are affirmed in that with minimal, really exploration. And, unfortunately, many of these young people have a lot of mental health issues, history of trauma, sexual abuse, and, instead of delving into those, the healthcare provider is obligated to affirm the person's chosen identity. And these kids then quickly get puberty blockers, cross-sex hormones, sometimes often at the first appointment. 1 or 2 visits, a 2-hour visit, then they walk out with a prescription. Gender affirming care is used by most clinics. It's endorsed by major medical organizations as well. Now, again, minimal evaluation, the diagnosis is made by the patient, and the transition takes precedence over evaluating the underlying issues. Now, this little picture here, this is a documentary, a very short documentary, like 10, 20 minutes or something, 15 minutes, by the Daily Caller called Do No Harm. There is a website called Do No Harm, so it's not that website, it's just the name of the documentary by Daily Caller. Highly recommend it. But what it is this young woman, she's probably 25, but she looks like she's 16. And she goes undercover to Planned Parenthood. She says, I want testosterone. And she videos the whole encounter where she goes in, has one appointment with very minimal evaluation. She admits to having depression and she walks out with a prescription for testosterone. So this is what's happening. for our young people. So I want to go over now a little bit about when somebody decides to transition, what those steps are. Not everybody goes through every step, but let me explain that. So the first one is social transition. That would be wearing the clothes, taking on a name of the opposite sex, dressing like the opposite sex. Then puberty blockers. If the person hasn't gone through puberty, they take a medicine to prevent their own puberty. And then they go on to cross-sex hormones. So a female would take male hormones, testosterone, and a male would take estrogen. So they take hormones of the opposite sex. And then some people go on to gender-affirming surgery. So we're going to go into each of these. Again, social transition, clothing, hairstyle, name, pronouns. But it goes beyond that. Girls may do chest binding to make their chest flatter, packing to provide a bulge at the groin. Now, this chest binding isn't just wearing a sports bra. It's really like tight compression of their breasts, very uncomfortable. Boys may kind of do the opposite, stuffing to make their hips and chest more prominent. And then this procedure called tucking to hide their penis and scrotum, which I'm sure must be very difficult and painful. And so some may say, well, social transition is reversible. Now, I suppose that social transition is logistically reversible, but it's not always easy to do. So imagine a 6-year-old girl who has been presented as a boy for 4 years at school. All her friends think she's a boy. She goes by a boy's name. She wears boys' clothes. She hasn't had any medical transition. It's going to be very difficult for that young girl to just show up at school and say, well, I'm actually a girl. So this can be very difficult. And social transition is not without consequences. Another book I recommend, Lost in Translation by Miriam Grossman. She's a child psychiatrist, goes through a very readable book about a lot of the details of this. But she says that chest binding it's really a gateway drug, so like social transition, it's a step toward the next steps. And again, social transition is not necessarily without consequences. We don't have a lot of data on this stuff. There's no peer-reviewed study on these interventions, but one study on chest binding showed that 97% of girls had adverse effects. So they'll have back pain or shortness of breath or chest pain. Tucking in boys, again, no definitive studies, but we have reason to think that doing this may affect sperm formation and fertility. So social transition, the first step, the one that probably the most people do first, is not without harm. Puberty blockers. So if a young person has not gone through puberty and they want to look like the other sex, then the next step would be a puberty blocker. And that's going to stop the normal process of their own puberty. This is an gonadotropin releasing hormone agonist, antagonist. So it stops the release of their hormones. Now, we use this drug, it's used in gender care off-label, but it's FDA approved for different treatments for endometriosis in women, for fibroids in women. And I've used it for those purposes. And I'll tell you, we only keep women on it for usually 6 months because of the side effects and the bone density issues and other things. I mean, it basically puts women in a temporary menopause because it stops their hormones. And if somebody has severe endometriosis pain, then that may be worth it. But it's also used for prostate cancer in men. And it's used for precocious puberty in children. So precocious puberty is when a child is going through puberty way, way, way too early, and that can just stunt their bone growth. And so it is given temporarily to stop this precocious puberty or until the time of their normal puberty. And some would say, oh, well, we use it for precocious puberty. Why can't we use it for, these kids with gender dysphoria? But it's not the same use. In one case, you're stopping an abnormally early puberty so that the child can go through puberty at the proper time. And so a kid with gender dysphoria, you are stopping the normal process. So Puberty blockers often presented, oh, just buy time. Parents are told, we'll just stop the puberty, and we'll buy them time to think. But the truth is, we have multiple studies. Almost all kids that go on puberty blockers go on to cross-sex hormones. They're not really buying time so you can decide which path to go on. They're sending you down a path. And there are harms. Decreased bone mineral density that may or may not be reversible. Loss of sexual function as a result, sterility, and there may be cognitive and neurologic effects. So they're not reversible, and they don't really buy time. They send you on the child on a path. So that's puberty blockers. Okay, then the third step that someone may go through is cross-sex hormones. So this is giving the opposite sex hormone. So in a girl would take testosterone. We know what testosterone does. She's going to grow facial hair and body hair, get a deeper voice, more muscle mass, more libido, enlargement of her clitoris, probably stopping of her menstrual period. For a boy who wants to appear like a girl, he will be given estrogen, increased body fat, decreased muscle mass, decreased libido, decreased sperm production, erectile dysfunction, decreased facial and body hair, and breast tissue growth. But there are harms from these hormones. A female who takes testosterone is at risk for heart disease and stroke, high blood pressure, liver problems, increased red blood cell concentration, and adverse effects on the lipid profile. A male who takes estrogen also at risk for heart disease and stroke, but also breast cancer and clots and benign tumors, gallstones, high triglycerides. So this is a quote from the Endocrine Society Clinical Practice Guidelines, which is very interesting because if the pair of guidelines, someone who is giving gender affirming care would follow the WPATH guidelines and the Endocrine Society guidelines. The Endocrine Society would be more specific about the doses. So these are people that are promoting these practices and claiming to be a practice guideline. And the Endocrine Society says future research is needed to ascertain the potential harm of hormonal therapies, yet they promote giving them to our children. Okay, then the fourth step, so to speak, is gender-affirming surgery. I'm going to get a little detailed here, and it's going to be disturbing because I think you need to know what's going on. So a girl who wants to appear male may have a mastectomy. This is the most common gender-affirming surgery is a mastectomy. They don't call it that. They call it top surgery. It's removing the breasts and making the chest look more male. She may have general surgery. So this is, they call it bottom surgery. We're doing a hysterectomy, removing her uterus, her ovaries, closing off her vagina, and then constructing a penis-like structure and prosthetic testicles. A phalloplasty or metoidoplasty are the two procedures to construct the penis-like structure. If a male on the other side wants to appear female, he's going to get breast implants, facial and vocal surgery, and then genital surgery, removing the penis and testicles, and then, yes, constructing a vagina-like pouch and external female genitalia. These surgeries have particularly high complication rate. They're permanently disfiguring and detrimental effects on sexual and genitourinary functioning. So I'm going to go through them all a little bit about the harm. So let's talk about female to male, removal of breasts, scarring and loss of sensation. But this young girl will never be able to breastfeed. We do mastectomies on women who have breast cancer to remove a cancerous breast to save their life. But what's happening is these normal breasts are being removed on these young girls. Removing the uterus and the ovaries, permanently sterile, will never be able to have children. And the decreased estrogen production, you remove ovaries in a young woman and she's no longer producing estrogen. You put her at a lifetime risk of death from cardiovascular disease, stroke, and all, as well as osteoporosis. Okay, then the more invasive surgery, a phalloplasty. So this is constructing a penis-like structure. A metoidoplasty is a less invasive, kind of smaller structure. Phalloplasty, very significant and frequent complications. So as high as, 76.5%. All surgeries have a risk of complications, but this is quite high. Fistula. So a urethral fistula means there's a connection between the urethra where the urine goes through and another organ of the body. Urethral stricture means the urethra is closed off. So these people are having very, difficulty and problems urinating. The complication rate from the metoidoplasty is less. It's a less invasive procedure, but almost 10% go on to have the phalloplasty. So then I'll talk the surgery male to female, breast augmentation, vocal cord surgery, facial feminization, genital surgery. They're not just going in and having a surgery. They're having multiple surgeries. Removing the penis and testicles. And then this is disturbing, constructing a quote unquote vagina. The most common way is to do what's called a penile inversion vaginoplasty. Yes, it's what it sounds like. So they're inverting the penis to make a vagina. If someone took puberty blockers, sorry. Okay, the cat walked over the presentation. I need to go back to my slide. Sorry about that. All right, are we seeing the slide okay? Yes, okay. If a young person took puberty blockers, they can't do this technique, so they use the intestine. And then they will have a malodorous discharge. So these are very high complication rates. Again, fistula, stenosis, stricture, and there's inconsistent data on sexual function. These are very invasive, destructive surgeries. I want to talk a moment about WPATH, the World Professional Association for Transgender Health. It sounds very official. They do publish what they call standards of care. This is their latest version, version 8. But it doesn't meet what I would call the qualifications for a professional medical organization or for standards of care. So this organization was started in 1978. They published their first standard of care in 1979. In 2007, they changed their name to WPATH. In 2012, they issued their version 7 of their standards of care, and then the latest version is version 8, issued in 2022. This is about a 300-page document going through, this is what you have, about the care for transgender people struggling with this. WPATH is not just an organization of physicians. It's also made up of activists, and well, their standards of care are not scientifically based. I'll get into that a little bit, but okay, let me tell you about their standards of care, because this is going to be appalling. Standard of care 7, so this is the prior one in 2012, for a young person to have intervention. They had to be at the age of majority to get hormones or surgery. So this would be 18 in this country. They had to have 1 referral letter, 2 for general surgery. If they were a minor, they had to have parental consent. And any medical or mental health issues had to be well controlled. This changed standard care 8. So this is 2022. This is the current standard. Well, they took off those age limits. There are no lower age limits for kids to have these interventions. They use what's called stage, the stage of puberty. Hormones and surgery, no lower age limit, no referral letters. Parental consent is preferred, but not required. And the mental health issues don't have to be well controlled. They just have to be addressed, whatever that means. So again, this is the first page of the standards of care. And this is about a 300-page document, very disturbing. So what they say here is that a young person can get puberty blockers and cross-sex hormones at Tanner stage 2. Well, Tanner stages are the puberty stages. Tanner stage 2 is just the very start of puberty. So, some girls go through puberty as early as 8 years old. So a girl just starts getting breast buds, she can get puberty blockers and cross-sex hormones. And then they prefer 12 months of hormones before they have surgery, but not required. So this standard care is allowing these very, very young kids to get these significant interventions. No referral letters, parental consent not required. And as I said, their medical mental health issues just have to be addressed, not well controlled. Now, you may have heard about the WPATH leak. I'll just mention this briefly. A couple years ago, some people got some documents from WPATH, and what they found out is what we already knew. It's not scientific, it's not ethical. It recommends arbitrary and unethical medical practice. It's not evidence-based medicines, and it violates obtaining informed consent. So, well, let's talk about, is gender-affirming care supported by the evidence? There are many, many studies, and I'm just going to talk about a few. I'm going to talk about where it started. So it started with what's called the Dutch protocol. So this all started in the Netherlands, where they decided, we have these kids with gender dysphoria. Maybe if we block their puberty, we'll see how they do. So they took 70 young people, gave them puberty blockers, and looked at the psychological effects over 2 years. Well, they had some improvement, supposedly, in behavior, depression, emotional problems, general functioning, but their gender dysphoria didn't change. No change in anger or anxiety or body dysmorphia. Well, something you need to know about this study. First of all, it's a small study. It's only 70. There's no control group. So they, usually do a control where you have one group that gets the treatment, and another group that doesn't get the treatment. And they should be blinded to who gets it or doesn't. And then you see who does better. Well, there was no control group. In fact, the kids they not only got puberty blockers, so they also got psychotherapy. So if they did have improvement, which one was the one that helped? The other thing is that this is a different population of kids than what we're seeing today. So these kids in the Dutch protocol had gender dysphoria since childhood. Most kids today, it's adolescent onset. They had a supportive environment, and they had no comorbid psychiatric disorder. So there was a second study, the same authors, excuse me, a few years later, they took these same group of kids and followed them out for longer term outcomes. They looked at their outcomes before puberty blockers, before cross-sex hormones, and 1 or 2 years after surgery. They found that in young adulthood, their gender dysphoria was alleviated and their psychological functioning has steadily improved. Well, this second study only had 55 of the 70. They excluded 15, including one who died of the very treatment they're studying. This young person died of complications of a vaginoplasty. Several of these kids were excluded from the study because they had complications, diabetes and obesity. Some dropped out. So the Dutch protocol studies, again, lots of problems with these. I just kind of summarizing them here. Different population than today, no control group. They received both psychotherapy and puberty blockers, and more than 20% were excluded from the study, one of whom died. I don't know of any study in young people in which 1 out of 70 die, and you say, well, this is a good treatment. And really the improvements in these kids were marginal. They were already well functioning in the beginning. So the problem is this isn't just a study that kind of looked into things and then other studies delved into it more. These studies, the Dutch protocol studies, form the foundation of youth gender transition today, and they have never been replicated. This is what it's all based on, 2 bad studies in which 1 young person died. And I could go through study after study after study, which obviously you don't want to be here till midnight, neither do I, but I'll just summarize by this. This is from the American College of Pediatricians, which I want to distinguish from the American Academy of Pediatrics. The American Academy of Pediatrics is pro gender affirming care. American College of Pediatricians is fighting this battle and is a more conservative organization. But they say there is not a single long-term study to demonstrate the safety or efficacy of puberty blockers, cross-sex hormones, and surgeries for transgender believing youth. So is there a benefit from gender affirming care? The studies that we have are low quality. There aren't long-term studies, very many long-term studies. There's very few randomized controlled trial. And in fact, I'll just point out, you've heard of the other countries speaking against this. This is older now. This is a Wall Street Journal opinion piece in 2023 where 21 clinicians, so these were people that were doing this gender transition, signed this letter and said, we have to stop this. There's no evidence, and we should be doing psychotherapy for these young people. So it was signed by people from many countries, but no one from the US. Again, no randomized controlled trials for the use of puberty blockers, including safety for stopping puberty. Finally, I want to bring this in. This is, interestingly, our government last year issued an executive order to study pediatric gender dysphoria treatment. And this is the report in May. It came out May last year. And then there was a revision in November. I think it was just some minor revisions. It's a 400-page document. I'm actually giving a podcast on this. I'm doing it tomorrow, going through this document with reasons to believe. I'm not sure when it will be published or whatever online. But so this isn't a guideline. It's not an edict. It's not telling anybody what they have to do, but they delve into the research and find that the evidence isn't good. We know there's harm. The evidence for benefit is uncertain. And I'll just read this. When medical interventions pose unnecessary, disproportionate risks of harm, healthcare providers should refuse to offer them even when they are preferred, requested, or demanded by patients. Failure to do so increases the risk of iatrogenic harm and reduces medicine to consumerism, threatening the integrity of the profession and undermining trust in medical authority. But they go through really in detail. This is a 400-page document on the studies on this and the level of evidence. This is just the update. This is the November one. I guess they updated the front too. Okay, so I'm going to ask the question here that we usually get asked, because parents are often, they take their kid to the gender clinic, and parents are uncertain about doing this, and then I said, well, do you want a dead daughter or a live son? Meaning, well, if you don't allow your daughter to transition, she's going to kill herself. What a terrible place for a parent to be. Is this true? Well, it's not true, but I want to frame it so in the right way. So first of all, suicide risk is already unfortunately increased among transgender youth. It's about 13 times average. As with mental health disorders, anorexia is 18 to 31 times. Depression, youth with depression have 20 times the risk of suicide. Autism, 8 times. And of course, transgender youth also have a higher risk of these other mental health issues. So they are at increased risk. But does gender transition decrease that risk? No, it doesn't. Now, WPATH says it does. They said, oh, gender affirming procedures have been shown to improve mental health. But this is simply not true. This is not true. This study is one of the few long-term studies we have. This is actually in adults. They looked at 324 patients who underwent sex reassignment surgery, and they matched them with each patient with 10 controls of their birth sex and 10 controls of their reassigned sex, so to speak. And then they followed them for 30 years. And the ones that transitioned, 19 times risk of suicide. So the best evidence we have suggests that gender transition increases suicide, and we have no evidence that it prevents it. American College of Pediatricians published a document on this. Prevention of suicide for trans-identified youth is the same as for other youth. Talk therapy and FDA-approved psychiatric medications. And again, their statement, no long-term evidence that mental health concerns are decreased or alleviated after gender-affirming therapy. So unfortunately, there's these young people really struggling with mental health, with their situation. They're being bullied, they've had trauma, they've had sexual abuse, they're depressed, and they are sold the lie that this is going to help them. And it has simply not been shown to be true. Very briefly, is gender-affirming care ethical? Well, you probably know what I'm going to say. I did publish a paper. This is a peer-reviewed paper published in the Lineker Quarterly with the Catholic Medical Association. And I'm going to give a podcast with reasons to believe on this in a few weeks. But just briefly, when we look at medical ethics, there's kind of 4 pillars. Beneficence means you have to act for the patient's benefit or do good for the patient. Non-maleficence means do not harm. Well, your harm, I mean, there's always a risk of harm, but your harm has to be, for example, a cancer patient might receive chemotherapy because it's going to benefit them and cure their cancer, even though it will harm them because they're going to lose their hair. So the benefits have to outweigh the harms here. Autonomy means the patient has a right to make their own decisions, and the physician is required to give them adequate information to make that decision. And justice, treatment must be fair, equitable, and appropriate. Beneficence. Is gender-affirming care beneficent? Does it do good? There's no evidence there's any benefit from gender-affirming care. We talked about this. Those are duplicate slides. Non-maleficence. Does gender-affirming care cause harm? Yes, it results in permanent disfigurement and detrimental effects on sexual and urinary function. Now, autonomy. Does gender-affirming care honor the patient's autonomy? You may think yes. Well, the problem is to have autonomy, you have to give the patient accurate information. You have to tell them the risks of the procedure. You have to give them their options, the advantages and disadvantages. And of course, you have to offer patients a treatment which is beneficial. And, unfortunately, gender-affirming care is assumed to be the standard of care when it's not. So patients are not adequately informed or evaluated. So again, autonomy means a patient can accept or refuse care. It doesn't mean a patient can just have any intervention they request. Informed consent, I talked about this. This is a big problem with gender-affirming care because informed consent means that if I'm going to do an intervention on a patient, I need to explain their illness, and I discuss why I recommend the treatment and the risks and benefits, discuss the alternative treatments, including doing nothing and those risks and benefits. And the patient must be competent. So informed consent means I can tell a patient, I recommend this chemotherapy. It's 99% likely to cure your cancer. They can still say no. But if I don't give them adequate information, then that's not informed consent. Well, gender-affirming care bypasses informed consent. Patients are told it helps rather than harms. They're not given accurate information, and it's a poor evaluation process. In fact, they use this model called the informed consent model, which is a terrible term because it's not informed consent. But the informed consent model basically means it's just provided based on their ability to say they want it, not whether their criteria are met. And then there's the whole issues of minors. Can minors give informed consent? This is a paper which talks about how children and adolescents do not have the cognitive or emotional maturity to comprehend the consequences of treatment, for which the end result is sterility, organs devoid of sexual pleasure, etc. Is gender affirming care just? The fourth principle. No. And just a quick line from the HHS report. They quote this from the Belmont report, and they say an injustice occurs when some benefit to which a person is entitled is denied without good reason, or when some burden is imposed unduly. And what's being denied these young people is good care and adequate care and psychotherapy. And so I would propose that gender affirming care is unethical. It's not backed by science, evidence-based medicine. It takes advantage of people in distress and the most vulnerable. These young people, they're often struggling with mental health, as I said, abuse, bullying. They need psychotherapy, support, and time, not harmful bodily mutilations. So that's the end of my presentation. I'm going to stop sharing, and I think we'll open it for questions.
Thank you. That was a wonderful talk. Very sobering too. Yes. So we have an opportunity for questions for anyone who wants to ask a question. Okay, go ahead, Jim.
Hi. So one question I had was just trying to think of how the law gets involved in all this. In other words, are the physicians or the counselors or whatever, are they obligated in any way to do one thing or another, or give advice a certain way or anything? Because in the state of California, I've heard a lot of stories about counselors not being allowed to say certain things. Do you know anything about that?
Yeah, I think that's a state by state basis. There was recently that case in Colorado that was a little different, but where it went to the Supreme Court and they won. But yeah, counselors are in a difficult place, and it's, again, states have different regulations. Everything's really in a state of flux here. I think that, there's kind of a little bit of a turn of a tide, but it's still happening. There's a lot of detransitioners, speaking out, and lawsuits happening, and we just have to keep praying that things will change. But yeah, I think, like you said, I think there probably are states where they're, required to do something. If you're a parent and you want to bring your child to a counselor to talk about their issues, you really have to be careful, obviously, who you take them to. That book by Miriam Grossman does talk about that, how to find a good counselor. So, you just can't take them to anybody who's going to buy into the practices. But it's a great question. Thank you.
Sure. What about the state you're in? Do you know anything about Pennsylvania?
I'm in Pennsylvania. I'm pretty sure it's all happening here. Right 10 miles down the road from me at our children's hospital. I will say, I just heard in Texas, they're opening the first detransition center. So, what happens to these kids that I didn't talk about detransition, but they get all this support when they want to transition, and then when they change their mind, I mean, they lose their friends, they lose their doctors won't take care of them, and they're kind of left out in the open, and they really need a lot of support. And so yeah, it's a tough situation.
Thanks.
Is it your opinion that gender dysphoria has increased significantly recently, or what? How do you explain the great increase in the number of cases of transitioning?
Well, that's a great question. So we have, like I said, kids identifying as transgender are certainly that's skyrocketed. It's gone up 700 times. But I don't have the data or whatever, but it seems to me most of these kids are suffering from a social contagion. They have mental health issues. They're under pressure. I don't know. I can't imagine what it's like to grow up on social media where everything you say or whatever is publicized to your friend group and you can never forget it and blah, blah, blah. And these kids are under a lot of pressure. And so, do they really have gender dysphoria or are they seeking something else? Obviously there certainly are people with gender dysphoria, but I think that a large majority of our young people who are transitioning are suffering from a lot of other things as well. Yeah. And then it's being promoted as being cool and the solution to the problems and all this. And, I can't imagine if think about when you were growing up, I don't know, I had two older brothers. They threw a football at me and I don't know, I wasn't a girly girl. So would I have been insecure about my own who I was as a girl just because of that? Well, no one ever questioned it back then, but now it's all being questioned. So there's all these questions being fed to these kids. Well, maybe you're really a boy. It's horrific.
Yeah, I understand one of the risk factors, particularly for girls transitioning, is one of their friends transitioning. So it
Right.
does really seem like there's a strong social component.
Yes, sure. Yeah, absolutely.
Yeah, Doctor, at the beginning of your presentation, you mentioned that it seems most of the U.S. medical associations are fully on board with the gender-affirming care. I know in Europe, there's been some rethinking of this as the evidence has been
Yes.
mounting against it. Do you think the U.S. organizations are prepared to change and to rethink this, or are they simply beholden to special interests?
Oh, that's a great question. I have no indication that they are going to change. Okay, so we're talking about the American Academy of Pediatrics, the Endocrine Society, American Psychiatric Association, American College of OBGYN. I'm very familiar with them as an OBGYN, and it's there. There are a lot of corollaries with gender care and abortion. So kind of think of it that way. No, they're not. They're firmly planted. And you're right that the European countries actually changed their guidelines. Finland and Sweden led that. And England with the Cass report changed all that. Now we don't have a federal or national, whatever edict. So I don't know, what's going to have to change the hearts. I think maybe these kids unfortunately suffering, and it might be lawsuits. It might be, malpractice lawsuits. It might be lawsuits to go to the Supreme Court and change the law and God changing people's hearts. But I don't see a break in the armor of the American Academy of Pediatrics or those organizations at all.
Okay, thank you.
On the brighter side, though, we did see a change in Johns Hopkins, didn't we? I mean, they used to provide surgery, and then they discovered that it didn't really help the prevailing psychological issues, and they quit, didn't they? Am I wrong on that?
Oh, well, I'm interested to hear that. Johns Hopkins was involved in the latest WPATH guidelines, interestingly. And this all started at Johns Hopkins. John Money, who was the pioneered a lot of this, was at Johns Hopkins. But please tell me what you know about, is Johns Hopkins no longer doing gender surgery?
That's
I'm
what
not
I
aware of
heard
that.
some years back. But maybe things have changed, or I could be mistaken.
So maybe you're talking about the 1970s when this like was in its early stages. I don't know the answer to your question. It's a good one. So I think there are, again, I think it's a state by state thing where states are saying you can't do this. And now there could be, if, the government decides that hospitals that do this gender surgery will not receive Medicaid funding, follow the money, that could be. And some hospitals have pulled back and stopped their gender surgery, but it's not overall happening. Yeah.
Okay. So it's probably not a big secret that whenever you take a knife and cut a person, you lose feeling, like you spoke earlier with a mastectomy.
Right.
A girl really doesn't get pleasure from, from her breasts anymore. And
Mhm.
is a vaginoplasty the same way?
So a vaginoplasty is in a male, meaning making a vagina in a male. But sure, all of these genital surgeries have significant effects on sexual function. They certainly try to preserve things, but you could imagine, I mean, it's just pretty invasive, massive manipulation of the human body to what it's not supposed to be. And yeah, I mean, these kids are, and just the drugs that they're given. So you block their puberty, you block the growth of their normal organs, which are designed to, grow and develop and into sexually functioning organs. You block those, and then you give them opposite sex hormones. Yes, these kids have lifetime sexual adverse effects. Absolutely. And they're
Okay,
not told that.
so taking a break away from transgender issues, a woman who has breast augmentation probably goes under the same deadening of the nerves, doesn't she? Or
Well, I'm not really hearing about breast augmentation, but no, because you're not removing her breast, you're adding a implant. So I don't, it
okay.
depends. And that's again, that's a little, yeah, that's kind of a whole nother topic. But I mean, we could talk about the ethics of breast augmentation. Um, but yeah, it's a different mechanism there.
In the quiet of my own room, I'd say that the 700-fold increase in transgenderism is due to a different group being attacked.
Is due to what?
A different group being attacked.
Yeah, it's our adolescents, it's our kids.
Well, thank you.
Thank you very much.
I have a question. I'm online here.
Yeah.
I'm not sure if I read a study or just heard an anecdotal connection, but that in some ways there seems to be a mirror of particularly in junior high age young women that suggests that some of the population that would have previously struggled with eating disorders is now struggling with the idea of gender dysphoria or is there a study that talks about that?
That's a great question. So I don't know specifically of the study you're asking, but I will tell you that, yeah, there's an overlap because so kids or young girls with eating disorders and anorexia are more representative in the transgender group. And yeah, and interestingly in that book about that I referenced there, Abigail Schreier says if a girl came in with had anorexia and she weighed 60 years old and said I'm fat, you wouldn't say, yeah, you are fat, lose more weight like that. But yes, it is there is an overlap there. So you are it's all the mental health disorders you will see more of that in the transgender kids, which is why they should be getting help for their mental health disorders rather than being told, here's the fix. This will fix your problem. But yeah. But yeah, thanks for bringing that study out. I'm not familiar with that in particular. So great question.
Chris, I'd heard that the Plastic Surgery Society, the College of Plastic Surgeons, have
Yes.
have basically said that they're not recommending any surgeries on minors for
Yes.
gender affirming care, and that's a fairly recent thing. Do you have any comments on that?
Yes, actually, thank you for bringing that up. They are the one society that kind of took a stand and made a statement and are kind of stepping back, which is great. But yeah, thank you for bringing that up. That's correct.
I have a question.
Yeah.
Yes, obviously those operations cost a lot of money. So
Yeah.
what I'm really curious is who's paying for all this operations around the world? I mean,
I think you and
you
me
know,
are.
well,
Well, I think
no,
it's a
is the
great.
insurance companies covering this or?
Yes, I think typically they are. I mean, it's obviously going to vary by situation, but typically they are. That's why they needed to keep it in the DSM as a mental disorder, um, to get insurance coverage. But insurance companies are paying for these. That it's crazy because yeah, and some people are making a lot of money off of this. That's
There's
a good
one
point.
thing, Doctor, that I'm really curious, get a little bit off the line, I guess, but time-wise, when women began to assert themselves as, they weren't getting the recognition, they felt they were equal with men, that goes back, I don't know how far back, but it seems to me as women were demanding that they be acknowledged, men were kind of being pushed aside and as being, I don't know what, kind of weak and
Yeah.
inferior. And so there's been this transition, and it just seems that this transgenderism kind of mushroomed at the same time that, we have this other cultural effect going on. So, is there a parallel?
Well, I think it's all connected. I mean, think about the feminism in the 60s and the birth control pill. Well, now you can have sex without consequences, and then abortion. And then, well, women, you can go to work, you don't have to be a mother, but what are we doing to women is taking away their telling them that being a mother isn't valuable. And then you know, oh, well, men can play in women's sports and we don't even know what a woman is. Like this is all really anti-woman, in my opinion. I, it's I'm not, it's also anti-boy if it's a young boy, but particularly it's this is because it is mostly young girls and they're telling them you're not good enough as you are, so you should be a boy. We'll just chop your breasts off, and then it's horrendous. I think there's definitely, I mean, I'm not a history buff to understand how those all intersect, but I think they do. And and think about, and I've done some work on, because my other work's on abortion, and I actually give a talk on uh, gender care and abortion, two sides of the same coin, because they really are. And you know for example, you don't need a diagnosis to get an abortion. You don't need a diagnosis to have gender transition, but they're both, harming women. And I forgot my point on that, but yeah, there's a lot of correlation. I think it is harming women. It's our young girls. It's so girls who feel like they aren't enough for who they are, or they're not safe, or they're in a very bad environment. And, and we want to have compassion on these people because they need help, but transitioning them to look like a boy isn't helping them. Yeah. Thank you for that question.
I was just wondering, maybe you covered this and I missed it, but what is the motivation for these organizations? You talked about the different pediatric associations and such. Is it purely like activists, or is there some sort of just are they just confused and misinformation, or I mean, it's always tough to assign motivation to people, but I just wondered if you had some sort of idea. I'm just trying to figure out what's the motivation for these people to do this.
Well, that's a great question. I obviously can't know someone's motivation. I can give you my opinion.
Yeah.
And again, I've asked this on abortion. Abortion, it used to be safe, legal, and rare. Women should be able to choose. And now they're pushing abortion like so much, like it's so great to have an abortion and it's so great to be transgender. And it's, we're not. So honestly, my opinion, I think it's demonic. I have no other. I mean, you have medical doctors that are trained and should know how to take care of people who are doing, again, abortion or gender care without really even telling people what the risks are or giving them options. This isn't.
I could see this could happen on a small scale in certain areas where people just make the wrong decision or they have their own motivations or whatever, but it's such a large scale.
I think we live in a very evil world.
Yeah.
I have cats that want to be in my.
I guess so.
I think we live in evil. I don't. I mean, you ask a great question that I have asked, and I just think it's an evil world that Satan is working hard, and it's. I mean, I'd love to know anybody else's opinion, but because it makes no sense.
I also wonder if there's some sort of, I mean, you kind of see this a lot with, I don't know if I can explain it, but the idea of almost like compassion for these people and thinking I have to do something. And so that's kind of what they came up with was you don't want to, and you don't want to offend people. And I don't know, maybe that's more on the social side. Social media tends to be very, want to say open to all, try not to be a critic, not to be a critic of anybody's opinion unless it's a very conservative opinion maybe or something. But it seems like there's this on the social media side that there's this whole idea of being accepting of all, and maybe that has some influence on things. I don't know.
Well, sure. And you're getting into a lot of what's going on in our culture. And, I would say we should be accepting and loving of people. That doesn't mean we lie to them. Love is not lying to somebody and telling them that this is beneficial. I have a acquaintance, a friend who's transgender, who's transitioned. This person has no idea I'm giving these kind of talks. So, they're in a group I attend and I pray for them. And, we should certainly love people, but that doesn't mean we promote something that is bad for people. That's not helping people. But that that is how the narrative is presented. Well, you're not loving if you don't,
right,
come across this way. We are to be loving and we should be very compassionate. These people are hurting. They have been sold a bill of goods and they've been given, they're struggling, and we should be loving them. That does not mean love is not lying to somebody or giving them. As a physician, it's my ethical obligation not to offer treatment that I know is not good for my patient. So, yeah, thank you.
Hi there.
Hello.
You mentioned how following transition surgery that the risk of suicide actually increases in many of these people. It seems like a rational response to that from those who would like be proponents of the gender affirming of gender affirming care would be they're not getting the social recognition or acceptance in our
Mhm.
So would you have some sort of response to that?
Well, I want to qualify what I said, and I presented a study. So that was one study. We don't have a lot of studies. Um, but that was a study that was impressive because it was over 30 years. So they're really looking at some long-term data, and it was in adults, and it was one study. So, that's not necessarily it's kind of the best evidence we have. And my point was that we don't really we haven't certainly have no evidence. The evidence we have indicates that um, certainly this isn't helping prevent suicide. It's promoting that. And you're saying that the other side would say what?
They would say like, well, maybe the risk is increasing because following surgery, they're not getting the acceptance at a national level. Like they're still getting conflict.
Well, I mean, that's kind of a global, I don't know if they're saying that. They very well may say that.
I
I'm
don't
sure
know
they
if they're
have,
saying it. It was just a question that came to my mind.
yeah,
I'm
I'm
trying
sure
to
they have.
anticipate the response.
You know what? The problem is you can't have those discussions. Like, I wish I could sit down and say, well, what about this study? You can't have those discussions because it's all like, oh, well, we know it helps them. So how could it's just the way our world has gone where the reasonable and rational agree to disagree, but let's discuss our differences is gone. Um, yeah, I think they ignore the study, honestly.
Well, thank you.
Yeah, but great point.
Any other questions on those of you who are on Zoom? You have another question? I did hear that Finland has come up recently as I understand, and you can correct me, they were saying that transitioning in minors was not appropriate.
Oh, yes, many of the European countries, Finland, Sweden, Norway, UK, many of the European countries. So a few years ago, they all started, I think Finland changed their guidelines in 2022. Finland led the way there. And yeah, because they saw what was happening, that this wasn't really helping people, and we didn't have the good evidence. And like that letter from the Wall Street Journal was all from, I think it was mostly Europeans. And yes, it's, we always think of, especially the Scandinavian countries, as being so much more progressive than the US, but they've really seen the light and put a brake on things. Hasn't happened here yet.
And again, getting to motives, it's hard to know, but it seems perhaps almost political that you can't say you're wrong and you can't admit that you have to just double down on things. Certainly that's the way it seems like here in California, that
Yeah.
our legislature is just doubling down on all this, and it's become,
Yeah.
it's just hard to believe that people are pushing so hard when, other areas of, the world are retreating from these things with good reason.
Yeah. It's a very sad scenario for sure.
Sorry, you talked about Finland and Sweden and such. No, you didn't happen to mention Denmark, where this kind of all got started. Is that because they haven't actually changed, or?
No, it started in the Netherlands. It was the Dutch
Oh, I'm sorry,
protocol.
the
I know.
Netherlands. Oh, that's right.
Yeah. Oh, I don't know. Did
So
I think most of those countries, Norway's changed. Denmark, you're asking me about Denmark.
well, I
I'm
was
not.
wondering about Denmark, but also the Netherlands, if that's where it got started.
Yeah, I'm not
That-
sure they've pulled back yet.
I
That's
know
a good question.
One problem, kind of dovetail on what Randy was saying, was that once you make a commitment of something, it's very difficult to change your, if you make a public statements, it's pretty difficult to change your viewpoint publicly.
Sure.
So
Yes.
yeah. So you mentioned this W path leak. Is that right?
Yes.
So I was just trying to figure out, what does W path was a a publication, right? Or an organization had a
It's
publication.
an organization, yes.
So could you explain again what that leak was all about? In other words,
Sure.
did they go to WPATH people or what? Yeah.
Yeah, and actually I just pulled up some notes. And Denmark, yeah, in 2023, Denmark restricted care in minors, but you're asking about the Dutch protocol started in Netherlands.
Yeah.
So the WPATH, what happened is, and you can look up it's a whole big file. I think it's called the WPATH files. They obtained emails and internal communications, and basically confirming. Again, I read the whole WPATH. It's just, I mean, as a physician, it's abhorrent. It's like, well, how can you? It's clearly not evidence-based just by reading it, but they uncovered all the internal communications. I don't know exactly how they got that data. And then the interesting thing, if you want to read about WPATH, if you pull up that HHS report, which is you can get online for free, and just go to the WPATH section, they talk about how the WPATH just ignored trials and ignored evidence and pushed things through without evidence and just clearly, yeah.
So has that been made public enough that people aren't, what do I want to say, people aren't paying attention to that report anymore, or those guidelines?
Yeah, it's that happened and people moved on, and people doing gender affirming care are still following WPATH guidelines.
Yeah.
It's
Okay.
it's crazy. Yeah.
Thanks.
Good question.
I did appreciate in your white paper that you mentioned the difference between compassion for the people with gender dysphoria and really, really loving them, and
Yeah.
also speaking the truth to transgenderism, which is more of a movement and not
Yes.
and being courageous in that.
Mhm.
I thought that was very helpful. How would you approach someone who held a different view that thought gender affirming care really was really a good thing, and you were going to have a conversation with them? How would you do that?
Yeah, that's a great question, and it obviously would depend on my relationship with that person. Like, if this is a friend, as I said, in a organization, a group that there's a transgender person, and I'm not having that conversation with this person. I'm just trying to be friends with this person, and this person and I actually have connected because we both are crazy cat people, and we always joke about that. And I'd love to sit down with Alex sometime and get to know Alex better, and etc. So in that context, it would be building that relationship. But if you're talking about on an academic level, so I think it depends where, you'd have to set some kind of parameters. But I think when it's a one-on-one thing, it's really just investing in the person. Nobody's going to listen to you. Alex really doesn't care about the data. I think Alex is struggling, and I just need to be this person's friend.
I did.
Well, doctor, it brings up a question that I'm really curious about. Are there people who've had sex change years ago who are promoting it for young people? Are there
Sure.
advocates?
Sure, some of the WPATH people, some of the people do the surgeries. Marcy Bowers is one of the major. No, I think she's made some of those people are actually, I'm not saying stopping it, but making some reasonable comments like, okay, maybe, but like Marcy Bowers is probably done the most transgender surgeries, and Marcy was born a male and had own surgery. So yeah, I'm sure. I think some of the people doing the medical interventions are transgender. Not all, but there certainly are some.
Hmm. Hmm.
Yeah.
I was thinking, as a Christian, we have plenty of reasons to object to transsexual surgeries and stuff. If I wasn't a Christian, I can't think of a philosophical or moral approach why I wouldn't agree with doing whatever you want with your body, especially if medical risk could be reduced. Why not do it? So I'm thinking if I had a friend that was doing that, I'd almost have to take it back to, is there a creator? Is the creator personal? Did he know what he was doing when he made my body as far as identifying who I am sexually? If I reject all that and leave it out, I can't think of a good argument to be against it. So it almost has to go back to a creation account and whether there's a personal God who we find identity in. Could you?
Well, yeah, I think that's a good point. I think a lot of, whether you can do something like that to your body, like from an overall perspective, goes back to that. But I think and again, there's so much more evidence that I didn't have time to present tonight. I just kind of did a very quick overview. But I've delved into all these studies, and there's simply, from a scientific standpoint, there is no evidence that this is beneficial, and there's clear evidence that it's harmful. So you don't have to be a Christian to say this isn't good for somebody. Now, whether it's okay to destroy your body, yeah, that's kind of goes back to like you said, I agree. But I think from a completely medical evidence, what is the best medical evidence? The best thing to do for these people from purely secular medical evidence standpoint, it's not transitioning. There's been no shown benefit.
It almost depends whether you're willing to take the risk, knowing what the risks are. And like I say, if medical risks could be reduced, what would be the reason to avoid sex change?
So there's no benefit. So there's
Yeah.
if you look at the studies, there is no high quality data showing that this helps people. We know it harms them, but there's no high quality data showing that it helps them. If you had 100 studies that were good studies showed, what, these people are depressed and they get transitioned and their depression is so much better. We don't have that. There's not that data because that's not the case. They actually do worse.
So it's 100% dissatisfaction with the sex change.
I'm sorry?
Nobody's happy with having.
Well, I'm not saying that. Obviously, I'm talking about from a scientific standpoint. Obviously, I'm sure there are people that would say, I had this done. I'm glad I had it. Whatever. But, everybody's different. But that's, there could be just like there could be somebody that said, I just cut off my arm. I'm happy I did it. Like,
Yeah.
but that's not if you don't go cutting off everybody's arm because it's not beneficial. So, I mean, sure, there's always going to be people that say it helped them. That's true with anything. There's going to be, but again, as a physician and a researcher, you look at the evidence. Is there evidence that this helps people? And like the HHS, their study, they delved into these studies and, the evidence of any benefit was very, very low quality. There was no good quality. So I would say if you're an atheist with integrity and you have a friend who's an atheist with integrity, you tell your friend, don't get this. It's not going to help you. I guess I'm saying you can justify it from a completely scientific standpoint.
Right. Yeah. Okay. Thank you.
Yeah. Thank you. That's a good question.
From what you've been speaking on, it sounds like there's a very strong reason not to do this type of so-called gender-affirming care. Are you or other people who have your view in the medical field able to get your message out into like editorials and journals and things like that, or because of ideology does that get blocked?
Oh, it's extremely difficult to publish anything. I can tell you from just abortion research, if the research is very good research but doesn't fit the narrative, it's almost impossible to get it published. The article I published on ethics, I put it's in a Catholic journal because they're one of the few that would publish anything like that. So yeah, there's a big publication bias for sure.
I just want to ask, did you
Well, if I can mention, Doctor, there was a book in 2005, Freakonomics. Have you ever heard of
Okay.
it?
Yeah, but what is it?
And well, it was by two economists, and they showed a lot of things. It was an interesting book, but there was one research that showed that crime in America was, particularly in the cities, was going to be going up. I think it was around the late 80s to the early 90s. They were anticipating a huge crime surge, and it didn't come. And they looked at the statistics, and they found that abortions of Black women increased like 5, 10-fold, whatever. And so what they said in this book is that these women who were unmarried and having sex and getting pregnant were able to go to abortion clinics and have the child, and that caused the crime to go down. That argument was very strong, in the book. I mean, I've never forgotten it. And it was a kind of, I think, an argument that was picked up by a lot who have, the press and whatever. But that's the kind of logic that they used, and, in favor of abortion. It was like, see, this is good for the economy. I don't know. I
Well,
just think that has,
yeah,
yeah.
abortion is very much harming the Black population because the percent of abortions in Black
Yeah.
women is way higher than the percent of population. There's more babies killed by abortion in New York City than are born Black babies. So we're killing our Black population.
Yeah. But I think they're using it to justify abortion.
Yeah,
I don't know.
I've not heard that
Yeah.
argument, but yeah, they use a lot of things certainly.
So I was just wondering, back at Randy's question about publishing and such. Sorry, have you actually tried to publish in anything, any of the more major journals and such that probably would be against what you have to say? And you have actually tried it to see what would happen?
In the transgender area?
Sure.
Well, I
Yeah,
don't
yeah.
honestly, I don't do research in transgender stuff.
Right.
I wrote I did the big project with Reasons to Believe. I've delved into the research enormously, and I wrote the ethical paper, and I did submit that to a major medical ethics journal, and it got rejected immediately. But I can tell you with most of my research is on abortion, and yeah, we certainly tried the major journals and they get rejected pretty quickly.
So I come from an engineering background, and we submit papers and such, and usually the reviewers have to give reasons for rejecting the paper. Does the same thing happen in your field? Do they actually give
Yes, but
reasons,
you're making
or-
the assumption it gets to the reviewers. So
Oh,
not in
absolutely.
medical literature, not all, if I
forgot
could
about
get a
that.
fair review, if it would go to reviewers, that's one thing. But yes, you're right, it would go to reviewers and you get the comments. But a lot of journals will reject, and I mean, they, in a sense, they have to. They get more articles than they can possibly send out for peer review, but they get rejected. They don't get sent for peer review, is the problem. But yeah, you're right.
Okay, yeah, I had not thought about that side of things. Question about I think at the very beginning of your talk, you mentioned how it was kind of like a one-way path, that once people start going down the path, that
Yes.
they very self. I can't remember what those stages were, but like one of the first stages was like wearing the clothes of the
Social
opposite.
transition. Yeah.
Yeah. Is it even happen at that point where once they do that social transition, you said that even at that point, they won't
Well,
change their mind, or is it? kind of
I
taken
think,
further?
again, I made the point that some of the social transition, I mean, Miriam Grossman calls it a gateway drug to the next step. But the data I was presenting was really once they start the puberty blockers.
Yeah. Okay.
I don't really know the data on social transition because there's certainly a lot of kids that, do that. And what percent of kids who socially transition go on to take cross-sex hormones? I don't know that percent, but it is with puberty blockers, it is a one-way, certainly almost all of them. Yeah.
We have time for maybe a few more questions. It's almost midnight on the East Coast where Christine is. So we don't want to keep her up unduly. And I think her cats need to go to bed too.
Oh my gosh.
Yeah,
Yeah, they don't sleep enough.
that's right. We're gonna get a nasty note from the cats if we don't end the meeting soon enough. But any other questions? Let me ask one final one, and that is, how much of the kids transitioning is due to parent pressure? I see cases of parents with young kids and asking them whether they feel like being a boy or a girl today, or I've heard of that. I haven't seen it personally, but how much do you think is parent related?
Yeah, I don't know that percentage. I think there's some of that out there, which is kind of sad. Like, oh, I heard this couple like, well, we're not gonna give the baby a name till they decide their gender. And I mean, you're already setting up the kid for problems. And of course, some of the more famous, like Jazz Jennings, it just seemed to me, I don't know if you've known that there's a whole documentary about this young boy who becomes a girl. And, I don't know. There's certainly some of those parents that seem to be doing that. But I think for a lot of parents, they don't know what to do. Everything was normal, and then their kid came home, and they take their kid to get help, and they're told they have to get them transitioned. And this is a very difficult place for a parent. And if you're struggling with that, I really read that book, Irreversible Damage. I mean, she talks about just get your kid out of their environment, move if you have to, get them off of social media. This is a social contagion, and it'll save your kid's life because they're being sucked into this vortex of this issue. But yeah, I think you're right. There are some of that. I don't know what the percent is. I mean, my gut is that most of it is not, but it's all the more sad. Like, parents should be protecting their kids. So,
Well, Chris, thank you so much for both your presentation and your willingness to stay and answer our questions. And thank you also for your courage. I know it takes a lot of courage both to be a pro-life obstetrician gynecologist and to speak the truth in the transgender field. So we really appreciate you, and we appreciate your time. So thank you very much for being.
well, thank you. Thank you for having me. This was great. I appreciate it. It was good questions and lots to think about and digest. And so thank you.
Yes.
Pleasure.
Thank you, and God bless you.
Thank you.
And thank you all, for those of you on Zoom and those of you here in the room, for being here. And next month we will be looking at change our shift of perspective, and we're going to be looking at the origin of the solar system. So it should be a very interesting topic also, and we'd invite you back. So again, thank you for being here. Christina, thank you so much again for your time.
Thank you.
And we wish you and pray for you and all the God's grace and the best for you.
Well, thank you so much for having me. You guys have been great and appreciate the opportunity.
Thank you. All right.